Hello. In the next half an hour or so, let us see how we can use neuromuscular monitor in routine anesthesia clinical practice. Traditionally, we as anesthesiologists evaluated the neuromuscular blockers using clinical criteria alone. This evaluation had its own disadvantage because of marked variation in sensitivity to individual patients for this relaxant. As a result, we do come across patients moving, coughing or barking during intubation. We can also come across patients having delayed recovery after the surgery. Let us see in the next half an hour how this neuromuscular monitor guides us use of neuromuscular blocking agents. In the last 6 to 7 decades, we are using routinely the muscle relaxant. This use of muscle relaxants has led to the concept of triad of anesthesia, that is narcosis, analgesia and muscle relaxation with addition of controlled apnea. The advantage of this is it facilitates in tracheal intubation, it improves the conditions for surgery, it can also reduce the depth of anesthesia which can be lightened, and as a result it causes less side effects, and also it improves post-operative care. Let us now briefly review normal neuromuscular transmission and see how depolarizing and non-depolarizing block results. So when come to normal neuromuscular transmission, the impulses from the brain cortex reaches the neuromuscular junction. Calcium is released into the presynaptic junction. This calcium causes release of several quantas of acetylcholine into the neuromuscular junction. As a result, these quantas of acetylcholine which are released acts on the post-junctional receptors. These receptors causes changes and leading to sodium and potassium channel activation. As a result, the depolarization will occur and muscle contractions is resulted. During depolarizing neuromuscular block, succinylcholine when administered binds to the alpha subunit of the receptor, which leads to structural alteration of the receptors, and then ion channel opens up, but for a longer period than the acetylcholine. But this initial depolarization results in contraction and then leads on to fasciculation. This effect persists and further action potential unable to pass down the ion channel. As a result, muscle becomes flaccid and there will be no repolarization. Rapid recovery occurs because succinylcholine is metabolized by plasma cholinesterase. This figure shows how normal depolarization will occur. Here you see that movement of sodium is inside and potassium goes outside. So as a result, there will be depolarization which occurs either due to acetylcholine or because of succinylcholine. During non-depolarizing neuromuscular block, there will be no structural alterations in acetylcholine receptors. Here there will be no initial depolarization but competing with acetylcholine on the binding site. But it causes smaller end plate potentials which are insufficient to trigger a contraction. Here we require more than 75% of the receptors to be blocked to have an effect. It is affected by prior succinylcholine, inhalation agents, pH, body temperature, age, electrolyte changes and disease. Here in this figure, it shows how non-depolarizing relaxants compete with acetylcholine receptors causing muscle paralysis. If we see this figure, it requires two acetylcholine molecules to open up the channels. So if we inject a non-depolarizing muscle relaxant and if it occupies one alpha subunit, it's enough that it will avoid further conduction of impulse. So as a result, muscle paralysis will occur. Coming to neuromuscular monitoring, why do we require neuromuscular monitoring? It helps us in assessing conditions for tracheal intubation. It assesses if degree of depth of block is sufficient for surgery, and it also helps in monitoring recovery from block to avoid awareness and assesses the need for reversal. How do we assess neuromuscular blockade? We can assess the blockade clinically and by using a neuromuscular monitor. Clinically, by assessing coughing, straining, movement, apnea, fasciculations, and recovery by hand grip, head lift and eye opening. Whereas when we use a peripheral nerve stimulator, assessment can be made by visual, tactile or recorded. Before we go into the depth of neuromuscular monitoring, we need to know little physics about current and frequency of stimulation. Let us start with threshold current. It is the lowest current required to depolarize the most sensitive fiber in a given nerve bundle to elicit a detectable muscle response. Supramaximal current. It is approximately 10 to 20% higher intensity than the current required to depolarize all fibers in a particular nerve bundle. This is generally attained at current intensity of 2 to 3 times higher than the threshold current. Stimulus frequency. The rate at which each impulse is repeated in cycles per second. For example, single twitch is commonly repeated at 10 seconds interval, that is 0.1 Hz, and tetanic stimulus is commonly consists of 50 impulses per second, that is 50 Hz. Coming to principles of peripheral nerve stimulation. Here, evaluation of muscular response to supramaximal electrical stimulation of a peripheral motor nerve. Here, reduction in response during constant stimulation reflects degree of neuromuscular blockade. Electrical impulses should be supramaximal, monophasic, rectangular, and optimal duration should be around 0.2 to 0.3 millisecond. An ideal neuromuscular monitor should produce monophasic rectangular waveform of less than 0.2 to 0.3 millisecond duration. It should produce constant current. It should be battery operated. It should be able to generate around 60 to 70 milliamps, no more than 80 milliamps. It should be able to deliver different modes of stimulation. Electrodes. Electrodes used can be surface or needle electrodes. This surface electrode should have a small conduction area of 7 to 8 millimeters. The skin should be dry and clean. Skin temperature should be measured. Site of stimulation. Any superficial peripheral motor nerve, when stimulated, produces an evoked response can be used to monitor. Clinically, mostly ulnar nerve is used. Median nerve, posterior tibial, common peroneal and facial nerve also be monitored. Different muscle groups have different sensitivities to neuromuscular blocking agents. Diaphragm is most resistant, which requires 1.4 to 2 times more muscle relaxant than adductor pollicis. However, onset time and recovery at diaphragm are shorter than at peripheral muscles. Orbicularis oculi reflects block at diaphragm better than adductor pollicis. Coming to recording of evoked muscular responses, we have three different types of recording, that is mechanomyography, electromyography and acceleromyography. Most commonly used method is acceleromyographic method of recording evoked responses. So coming to the mechanomyographic method of recording the evoked responses, here we measure the tension after an isometric contraction. You give a preload of 200 to 300 grams at the thumb. After stimulation of the ulnar nerve, the thumb acts on a force displacement transducer. Force is converted into electrical signal, amplified, displayed and recorded. It requires control measurements which is recorded for 8 to 12 minutes with stable response before injection of muscle relaxant. It requires a precise setup, arm boards, etc. and it is mostly used as a research tool. This figure shows the complex setup of mechanomyographic method of recording the neuromuscular monitoring. Coming to electromyographic method of recording the evoked response, we record the action potential produced by stimulation of peripheral nerve. Stimulation of ulnar nerve, EMG is obtained from hypothenar or thenar by surface or needle electrodes. Results displayed as percentage of control or TOF ratio. It is easy to set up. Muscles which are not available for mechanical recording can be used. Disadvantage of this is it may be sensitive to hand positioning, direct stimulation of the muscles by recording electrodes. It is sensitive to electrical interference which is caused by diathermy. This figure shows the setup of electromyography where electrodes are placed over thenar, hypothenar and dorsal interosseous muscle. Coming to the acceleromyographic method of recording the evoked response. This is the most common method which is used in routine clinical anesthesia practice. Here we measure the acceleration at the thumb. This is based on Newton's second law, where force is equal to mass into acceleration. Here we use a piezoelectric ceramic wafer sensor at the thumb, which is exposed to force and generates an electrical voltage which is proportional to acceleration of the thumb after the nerve stimulation. This signal occurs whenever the thumb moves. It is displayed on the recording system. Coming to setting up of a TOF monitor, we need two pre-gelled silver chloride electrodes having 7 to 8 mm diameter of conduction area, an adhesive plaster, TOF guard or watch monitor. Carefully prepare the skin so that resistance between the surface electrodes and the skin can be reduced by removing the air, decornifying, degreasing the skin and cleaning the area beneath the electrodes with alcohol. Identify the palmar crease, tendon of flexor carpi ulnaris muscle. Optimal nerve stimulation occurs when the negative electrode is placed directly over the nerve, that is 1 cm proximal to the palmar crease and lateral to the tendon of flexor carpi ulnaris muscle, where ulnar nerve travels. The proximal positive electrode is placed 2 to 3 cm proximal to the distal electrode. Fix all the 4 fingers with adhesive plaster to the armrest. Fix the piezoelectric ceramic wafer sensor to the thumb on the palmar side. Fix the temperature probe to the hypothenar eminence. Monitoring should be started after induction before administration of neuromuscular blocking drugs. Select supramaximal current. Select appropriate mode for stimulation. Observe and interpret the evoked responses. In the acceleromyographic method of recording, we record single twitch. Here we give a single supramaximal stimulus of 0.1 to 1 Hz. Routinely during induction of anesthesia, we use 1 Hz as a stimulus for single twitch. The limitation of this method of assessment is it requires a control stimulus before injection of muscle relaxant. Coming to train of 4 method of stimulation, this is the most common method of stimulation used in routine clinical anesthesia practice. Here we give 4 supramaximal stimulus every 0.5 seconds interval and it is repeated every 10 to 12 seconds. Fading in response is basis for evaluation. TOF ratio is nothing but the ratio of amplitude of 4th response to amplitude of 1st response. A TOF ratio of 1 should be obtained before administration of muscle relaxants. In partial non-depolarizing block, TOF ratio falls, which results in fade, whereas in partial depolarizing block, there will be no fade. If fading in depolarizing block occurs, it might be because of dual block. Advantage of this block is it is less painful than tetanic stimulus. It does not affect degree of neuromuscular blockade. This video shows the normal TOF response. coming to tetanic stimulation, here we give 50 Hz stimulation for 5 seconds, and in depolarizing block usually the response is sustained, whereas in non-depolarizing block or dual block, fading followed by post-tetanic facilitation is seen, and which is due to increase in twitch response due to increased mobilization and synthesis of acetylcholine caused by tetanic stimulation. Traditionally used to evaluate residual neuromuscular blockade. However, it is painful and little used clinically. Coming to post-tetanic count, it is used to determine the degree of block in intense block, where there is no response to TOF or single twitch. Here, we give a tetanic stimulus and a pause for 3 seconds. Then we give 15 single twitches at 1 Hz and responses are counted. It is mainly used when no response to TOF or when sudden movement must be avoided, such as in ophthalmic surgery or neurosurgery. For example, no coughing or barking with tracheobronchial stimulus. If you want, we should have a PTC of 0. In this video, we see less responses to more number of responses, which indicates when we have less response, the depth of block is too deep, and when we have more responses, the depth of block is much lighter. Double burst stimulation. It is developed for tactile detection of small residual neuromuscular blockade, where there is no TOF is not sensitive enough. With double burst stimulation, it is easier to feel the fade. What we do is here we give 2 short bursts of 50 Hz tetanic stimulus, 750 milliseconds apart. Duration of each impulse is 0.2 milliseconds. Here, fade occurs correlating with TOF ratio. Absence of fade after double burst stimulation means clinically significant residual block does not exist. Evaluation of non-depolarizing block. Intense block, it is the period of no response after 3 to 6 minutes after injection of muscle relaxant, and no response to TOF or single twitch. Surgical blockade. One response to TOF reappears, gradual return of 4 responses to TOF. If we have one response, degree of neuromuscular blockade is 90 to 95%. When we have 4 responses, the neuromuscular blockade is around 60 to 85%. 1 or 2 responses indicate sufficient relaxation for most surgical procedures. When we require more intense block, it can be evaluated using post-tetanic count. Antagonism should not be attempted in intense block. Reversal might be inadequate. At least 2 or 3 TOF responses should be present. This video shows non-depolarizing blockade. During recovery, 4th TOF response heralds recovery, and it is good correlation with clinical signs. A TOF response of less than 0.4, patient is usually unable to lift the head, and if we have a response of 0.7 to 0.75, patient can open eyes, stick out tongue, cough, lift head for 5 seconds, and a ratio of more than 0.8, it excludes residual neuromuscular blockade. This video shows recovery from non-depolarizing blockade. Evaluation of depolarizing block. Phase 1 block. There will be no TOF fade and no post-tetanic facilitation. Patients with abnormal plasma cholinesterase or after long infusion of succinyl choline may develop phase 2 block, which is also called as desensitizing block, and which results in fade and post-tetanic facilitation. This video shows depolarizing block. When should a nerve stimulator be used? Actually, there are no contraindication for use of this nerve stimulator. When we use this nerve stimulator, it guides us optimally to use neuromuscular blockades in the following conditions. This monitor benefits maximally in patients who have abnormal pharmacokinetics, like in patients who are having severe liver or kidney disease, who are severely ill, in ophthalmic and neurosurgery, and in patients with abnormal pharmacodynamic changes like neuromuscular disease, and in patients with drug induced reversal is undesirable like severe heart disease or bronchial asthma. Post-op muscle power should be maximal, as in severe pulmonary disease or obesity during long procedures, and when we infuse the relaxant continuously for longer surgeries. These are some of the situations where the use of neuromuscular monitor benefits us optimally in titrating the doses of neuromuscular blocking drugs. To conclude, use of nerve stimulator during induction, patient should be unconscious, single twitch of 1 night should be given, switch over to train of 4, obtain a control response before injection of muscle relaxant. Good conditions for intubation will be around 30 to 60 seconds after response to TOF disappears. During surgery, response to TOF after succinyl choline reappears within 4 to 8 minutes in patients with normal plasma cholinesterase. Induction with non-depolarizing muscle relaxants leads to longer intense block, no response to TOF or single twitch. Time until return of responses to TOF can be evaluated with PTC. To ensure paralysis at diaphragm, block must be so intense that PTC at the thumb should be around 0. During reversal, antagonism not to be initiated before 3 or better 3 responses to TOF detectable or obvious clinical signs of returning neuromuscular function is seen. If all 4 responses are present and cholinesterase inhibitor is injected, reversal is usually sufficient in less than 10 minutes. Tactile estimation of TOF ratio or fading, however, is difficult. Double burst stimulus should be used to exclude residual block. Manual evaluation should always be considered in relation to clinical signs. The real value of this monitor lies in the fact that they guide optimal management of patients receiving neuromuscular blockers.